how to prophylax patients against VTE in pregnancy and postpartum. So this is the middle presentation. Last week we talked more about risk factors. Today we're going to talk about mechanisms for treatment. And then next week we're going to go over a sample of a bundle and how to make sure that we're appropriately managing our patients. And Michelle Flanagan is going to lead that, and I'll be working with her on that. So we'll wrap this up with a pretty little bow, hopefully next week, and finalize it with any questions you might have. So today, talking about different schemes for prophylaxis, how weight may alter prophylaxis, and the importance of repeated assessment for risk factors as we go through the pregnancy. Next slide. So risk factor assessment, we talked about that. I'm not going to go into a lot of detail, but again, the prime time is pre-pregnancy, so patients can understand that it is a big deal in pregnancy, but we all know most of the discussion doesn't come until they're pregnant. That first prenatal visit, we really need to uncover risk factors and talk about whether the patient needs to be on prophylaxis or not. And then when the patient's admitted to the hospital at any time, whether it be antepartum or for delivery, and then if they develop a pregnancy complication or let's say has to have a cesarean section, that alters the risk factors. So you have to update the risk factors and determine, do you need more in way of VTE prophylaxis for that patient? Next slide. So I'm not going to get into a lot of the mechanical stuff. Michelle probably will get into some of this next week, but lateral decubitus decreases pressure on the vena cava, decreases stasis, and theoretically decreases the risk of clots. Just makes sense. Elastic compression hose have been shown in some studies to benefit in certain patients. The pneumatic compression devices are very helpful in low-risk patients, particularly in those that are immobilized, whether it be at home or in the hospital. We're going to spend most of our time talking about low molecular weight heparin today, a little bit about unfractionated heparin, but the oral agents I'm going to leave for questions and another time. We don't use those in pregnancy for lots of different reasons, but we can discuss that at another time. Next slide. So what do we use? And in recent years, it's really fallen to prophylactic or the use of low molecular weight heparin. The one that we use most commonly is enoxaparin. Low molecular weight heparin seems to have lower bleeding complications, more predictable therapeutic response, lower risk of lowering the patient's platelet count. Not in prophylactic use, but it does not seem to have an association with decreased bone mineralization, which unfractionated heparin does. But again, with prophylactic use, that's not an issue. The drawback to low molecular weight heparin is that there's really not a good mechanism to reverse its effect other than giving blood products to do that. So we have to be cognizant of that when we're using it. But otherwise, it's a very, very good medication for VTE prophylaxis and for therapeutic dosing. Prophylactic use is 40 milligrams a day is the classic use. I'm going to go down to the third option here, therapeutic use of low molecular weight heparin, and it's also called adjusted dose. And that's basically where you want to fully anticoagulate a patient and you give a milligram per kg and you dose that every 12 hours. Now, the intermediate dose is what a lot of people use to overcome the weight issues. That's giving the Lovenox 40 milligrams or an adjusted dose twice a day. And that makes sense because of the volume of distribution and increasing the pharmacokinetic range for Lovenox by giving it 12 hours. Every 12 hours, you get a better coverage, even though you're not fully anticoagulating the patient. If you notice at the bottom of the slide, it also says extremes in body weight, modification may be required. And ACOG has not been a group that has published any recommendations about weight-based dosing other than the therapeutic ranges. And I'll go over that, an example of what I use anyway, in just a few minutes. Next slide. Not going to talk much about prophylactic unfractionated heparin, except to say you can see with a shorter half-life, you have to dose it more often, even for prophylactic use. So we don't use this very often. Have to go up on the dose every trimester because of, again, the volume of distribution. And it's very hard to get therapeutic levels of unfractionated sub-Q heparin. Postpartum anticoagulation is just some means of VTE prophylaxis or some dosing of heparin from 6 to 8 weeks postpartum. And then surveillance is just that. You watch the patient and adjust based on development of risk factors. Next slide. So this is the weight-based regimen that I like. It's from the Royal College. There are several different ones out there by the chest surgeons and the pulmonologists, but this is the one that seems to make the most sense to me. I have this posted next to my desk and refer to it regularly, but this is the prophylactic dosing I use because of the high incidence of obesity in our population. So you can see 40 milligrams a day, 60, 80, and so forth. Their high prophylactic dose is really what ACOG and others talk about intermediate dosing. So it basically takes that weight-based regimen and you give it every 12 hours. So you would give the 60 to 80 of the 0.6 milligram per kg, and then you would give that same dose twice a day. Next slide. So this is one of my favorite ACOG bulletins, and not because I think it's extremely accurate or even evidence-based, because it's not. But before this came out several decades ago, we really didn't have any guidance at all to help us determine which patients really should have some type of VTE prophylaxis. And this bulletin really helped do that. I was actually on the committee opinion panel when the practice bulletin panel put this together. And again, I've said this on many occasions talking about these bulletins. If you could see them putting this together, there's very little, if any, evidence put behind these recommendations. It's expert opinion, and it's very helpful, like I said, but understand that's why there's so wide a range of possibility in suggested treatments. I'm going to go through each one of these steps briefly, just to make sure that you kind of understand it, and then we can answer questions at the end of the presentation. But obviously, if no history of VTE, no thrombophilia, just surveillance and reassess risk factors and add prophylaxis if needed based on risk factors. If a patient has a VTE diagnosed in pregnancy, everybody would agree you need to have that patient on therapeutic low molecular weight heparin or unfractionated heparin and continue that treatment 6 to 8 weeks postpartum. Where it becomes a little bit less clear is when you get beyond that. So the next category, if you've had a single provoked VTE, now that is a VTE that's been associated with a surgery, a trauma, a patient's been immobile from a fracture or something, not related to estrogen, not related to pregnancy. The recommendation by the committee was surveillance without any therapy. And postpartum, the same, surveillance without any therapy, unless additional risk factors develop. Let's say a patient has a cesarean section or has choreo and a C-section. Next slide. So if there's a history of a single unprovoked VTE, that is a VTE that was either in pregnancy or while on hormonal contraception, not on long-term anticoagulation, and those patients deserve some type of VTE prophylaxis. And you get to choose. Is it prophylactic pure prophylactic dose, the lowest dose, is the intermediate dose or adjusted dose. And the way I decide where to go with this, it depends on the patient. And I talk about the adjusted dose, the therapeutic being the Cadillac. It's going to give you the highest protection, but there are risks associated with full anticoagulation. The prophylactic dose gives good protection, but it doesn't protect against all VTE. And then the intermediate dose, higher dose, slightly higher risk, gives slightly higher protection. And I let patients kind of help me decide where they want to go with their dosing. In the postpartum period, we do the same thing for 6 weeks in that patient population. If a patient has a low risk thrombophilia without a previous VTE, this is an area that really I changed my practice, because I used to prophylax these patients, but the committee suggests surveillance without therapy. Some people still give therapy in this population, but I have stopped in this group. And this is where I differ a little bit. In the postpartum period, I do give prophylaxis in this group, but they recommend as well surveillance without anticoagulation therapy, but institute it if risk factors occur. Now, if you take patients with a risk factor, a low risk thrombophilia, with a family history of VTE, then it can be surveillance or prophylactic low molecular weight heparin. And in the postpartum period, the difference is they do suggest some form of VTE prophylaxis in that patient population. So the addition of a history of VTE in the family makes a difference. And you can see down at the bottom of the slide, on any of the slides, it outlines what the low risk thrombophilias are. That is factor V latent heterozygote, prothrombin heterozygote, protein S or protein C deficiency, and antiphospholipid antibody. Next slide. So if a patient has a low risk thrombophilia with a single previous VTE and they're not on therapy already, some form of prophylaxis is indicated, and that's either the low dose prophylactic or the intermediate dose. And then postpartum, continue with the same. If they have a high risk thrombophilia without a previous VTE, those patients do deserve some type of VTE prophylaxis during the antepartum period as well as postpartum. These patients are at a much higher risk of developing a clot. And then if a patient has the high risk thrombophilia with a previous VTE, then those patients definitely need VTE prophylaxis as well. And in those patients postpartum, you can use any dosing protocol you want to, but we generally will step it up at least to the weight-based or the intermediate dose. Next slide. And then remember from the first talk, we talked about the most important risk factor is prior history of VTE. Those are big deals. If a patient's had 2 or more episodes of VTE, not on long-term therapy, they need to be on at least intermediate dose. And most people will use therapeutic doses of low molecular weight heparin and continue that into the postpartum period. And if a patient has had prior VTEs on long-term anticoagulation, then we continue the therapeutic low molecular weight heparin into the antepartum and postpartum period. And they can be switched to oral anticoagulants at any point, depending on which one they were on. Warfarin you can use with breastfeeding. You just have to follow the levels. The other agents do cross the breast milk, and it's recommended to remain on Lovenox or go to warfarin therapy if you do want an oral agent. Next slide. Just a reminder of what the high-risk thrombophilias are: factor V latent homozygous, prothrombin gene homozygous, or heterozygous for both of the above in the same patient, and antithrombin deficiency. These patients are at the highest risk and require some type of VTE prophylaxis and treatment. Now, just a quick word about using VTE prophylaxis and concern for epidural hematoma risk with regional anesthesia. We used to switch our patients over to heparin, unfractionated heparin, at 36 weeks. And then when there was a tremendous heparin shortage, we stopped that. And we have actually continued treating our patients with low molecular weight heparin right up until delivery. Again, just has a better therapeutic response, and it works better. And I try to hold that last prophylactic dose 12 hours before for vaginal delivery. If they're on therapeutic doses, 24 hours or 12 hours or 24 hours before regional anesthesia. So if I'm going to bring a patient in for an induction or even a primary C-section, I use these limits to help me determine when they can have regional anesthesia. And the Society of Anesthesiology, as well as perinatologists and anesthesia, agree with these numbers. This is kind of what we use. What I tell patients, if they're on the Lovenox and we've continued it, I ask them to hold the dose if they're having contractions at their next scheduled dosing time. And if they miss a day, it's not that big a deal. They can start it back if they're not going into labor. But that way, they at least have the alternative of having an epidural if they're going into labor. Next slide. And I just put these two slides, this one and the next one, in just for your reference. We talked about the risk factor scoring system last time, and I really do think that this is a great system to use to at least keep your head in the game when you're talking to people about risk factors, particularly in that first prenatal visit and when they come back and after they've had the baby, just to make sure that we're arming our patients with the best information that we can and give them the best chance to avoid a catastrophic complication, a leading cause of maternal morbidity and mortality, really around the world, but even particularly in our country. So it seems as I'm missing something. I'm not sure if Dr. Johnson's on, or Dr. Gailey or others might have other comments or questions. I do have a very quick case to present. It's not a big case, so I'm happy to stop and let everybody chat in some questions should we have them.